Good day, ladies and gentlemen. I'm Clement Tham from the Chinese University of Hong Kong. Before I begin, let me thank Dr. Partha Biswas and also the scientific committee of the All India Ophthalmological Society for allowing me this privilege and honor to share with you some of my ideas on the management of primary angle closure disease with all of you. Now, first of all, these are my financial disclosures, and then also some of the government funding that has supported our PACG work. Now, first of all, the word primary in primary angle closure disease, I think in a way it is misleading because the word primary often implies that this is one single disease entity. It implies that there is perhaps one management approach, and also it may imply that there's no underlying cause or mechanism that is known. But however, in primary angle closure disease, actually we are aware of several possible mechanisms that lead to angle closure, and these include pupil block, plateau iris syndrome, perhaps a lens-related mechanism, and also possibly choroidal pressures. Now, very often, whether in research or in clinical practice, we all often lump all primary angle closure disease into this one single entity. For example, in research studies, we will just randomize a whole spectrum of primary angle closure disease into receiving different treatments. Now, let me try to draw an analogy here, which is the red eye RCT. Suppose if we come up with a randomized controlled trial that looks at the treatment for red eyes, and I do not care about the underlying cause of the red eye. I don't care whether it is autoimmune, whether it is uveitis, or whether it is infective. But I recruit all cases of red eyes and then randomize these red eyes into receiving either topical steroid or topical antibiotics. And at the end of the day, I say that amongst those eyes receiving topical steroid, perhaps the improvement in the redness is significantly faster than those receiving topical antibiotics. And so I concluded that all red eyes should receive topical steroid. Does this make sense? Is this logical? I don't think so. I think management of diseases, including primary angle closure disease, should be based, whenever possible, on the underlying mechanism that is most important for that particular situation, for that particular individual and that particular eye. Now, with this figure here, I'm trying to show you the contribution of the different mechanisms of angle closure in different eyes. You can see that this column, the height of the column, represents the anatomical predisposition to angle closure. So the higher the column, the greater is the risk of development of angle closure. And you can see that in different eyes, the predisposition varies in severity. And also, in different eyes, the different mechanisms leading to angle closure also differs in proportion. Say, for example, in eye number 3 here, it seems that plateau iris is the main mechanism leading to angle closure, whereas in eye number 4, perhaps the lens thickness is the main mechanism leading to angle closure. Now, this figure here looks very similar, but this time in this graph, it is actually the same eye of the same patient, but going through different ages. You can see that with increasing age, the risk of anatomical angle closure increases. And also with increasing age, the importance of lens thickness as well as pupil block increases. So I think in the very first step of management of cases of angle closure, the objective is perhaps to remove the greatest chunk from this risk column by selecting one procedure or a combination of procedures that is most effective, but at the same time carries the least risk. Now, in the next 2 slides, I'm going to share with you 2 hypothetical situations which are at the 2 extreme ends of the angle closure treatment spectrum. In the first situation, we have a hypothetical 360 degrees complete appositional angle closure with ocular hypertension with or without glaucomatous optic neuropathy. In this situation, if there is visually significant cataract, then we perform cataract extraction. If there is still persistent appositional angle closure with plateau iris syndrome, then we consider argon laser peripheral iridoplasty. Whereas on the other hand, if there is no visually significant cataract, we may start with laser peripheral iridotomy. If there is still persistent appositional angle closure with ocular hypertension afterwards, then we would have to decide whether the plateau iris syndrome or the lens is the main mechanism leading to angle closure, and then treat accordingly. Now, in the second hypothetical situation, we have a 360 degrees complete synechial angle closure. Now, in this situation, even if you have done something such as cataract extraction to deepen the anterior chamber, chances are that the trabecular meshwork is still not accessible for aqueous drainage because of the synechial angle closure. So in this situation, if there is visually significant cataract, we remove the cataract with or without another IOP lowering surgery. If there is no visually significant cataract, then we would have to decide how important the lens is in contributing to angle closure. If it is very important, we consider clear lens extraction with or without another IOP lowering surgery. Whereas if the lens is deemed not so significant, then we would consider one of these other IOP lowering surgery for this particular patient. Now you can see that with this management algorithm, very often we have to decide between plateau iris or the lens being the main contributing mechanism. And let me share with you some possible ways we can distinguish between these two. I think the most important evidence supporting plateau iris syndrome comes from either darkroom gonioscopy or ultrasound biomicroscopy. So with darkroom gonioscopy, you can see that, for example, in this particular eye, just by putting on the gonioscope, you do not see any angle structures. So the next step, you would have to do indentation to see whether this is synechial or appositional angle closure. Now, after indentation, the angle reopens, and so this eye has appositional angle closure. You can see that now the trabecular meshwork is revealed, but there's one additional sign you can see from this photograph, which is what we call the double hump sign, which is classical of cases with plateau iris syndrome. You can see that the iris, there's first hump over here, which is the iris draping over the very prominent anterior surface of a thick lens. And then the iris dipped downwards, creating a valley, and then the iris rising up again over a very prominent and anteriorly positioned ciliary body and processes complex. So you can see this double hump, which is a very good sign indicating plateau iris syndrome. Apart from darkroom gonioscopy, you can also use ultrasound biomicroscopy to look at a cross-section of the very prominent ciliary body and process complex, which pushes the peripheral iris, narrowing the drainage angle. And when the eye is in a dark situation with the pupil more dilated, the angle is then closed off completely. Now, there are, of course, also evidence that supported lens being the main mechanism. Of course, you can do all these measurements, but perhaps the most important sign is a very shallow central anterior chamber depth, which is the combined result of both the lens thickness as well as the anterior-posterior position of the lens. Apart from the central anterior chamber depth, another very important sign is what I would call the Mount Fujiyama sign. You can see that when we are looking from an angle at the anterior surface of the iris, the pupil, and the lens surface, in an eye, with the lens being the main mechanism of angle closure, it does take on the appearance of a volcano. This is because of the thickness of the lens as well as the very anterior position of the lens. And so the iris is being draped over this prominent anterior lens surface, creating the appearance of a volcano. So thank you very much again for your time. If you're interested in more contents on glaucoma or perhaps on other areas of ophthalmology, please do take note of our first ever virtual APAO Congress in the year 2021, this year, which will be held from the 5th to the 11th of September. I very much look forward to seeing many of you at our first ever virtual congress. Thank you very much indeed.